Thanks for waiting, guys. We'll be starting at 6:05, so just 3 minutes.
Hello, Maria, can you hear me?
Hi, yeah, I can hear you. Can you hear me?
Yes. Do you have screen sharing capabilities?
Yes, I do.
Okay, perfect. All right, I think we can get started. Hello, Maria. Thank you so much for offering this incredible opportunity for our Wayne State University students. My name is Bisma Rana, and I'm the president of Club Med Virtual. I will be leading today's session, reading any comments posted in the chat, and facilitating the conversation as we go along. Before we start, I want to remind everyone to maintain proper etiquette and please keep themselves on mute unless Maria specifies otherwise. If you have any questions, please post them in the chat and we will address them as we proceed through the session. A Google survey will be administered for Wayne State University students at the very end of the session to verify your attendance and will close 30 minutes after the session terminates. Please stay on the call for at least 5 minutes after the session is over to ensure that the survey is working for you. This session will also be posted on YouTube in case you are unable to attend or want to revisit certain topics Maria discusses today, but you cannot receive attendance hours if you are not present in this call and complete the survey. So Maria will be starting off with her own presentation that she prepared for us, and then we'll go into a Q&A session whenever you're ready.
Hi, I'm ready. Do you want me to just start my video and share a screen or?
Yes.
Okay. Hold on. Here we go. Hi, everybody. All right, my name is Maria. I am a PA student here at, I think it's posting on YouTube, so maybe I'll avoid that. I'm a PA student in Michigan, and I'm in my 2nd year, and I've just finished up my endocrine rotation. And I'm starting my 3rd rotation. So today I'm just going to go over a case study with you and ask you guys some questions, maybe help you along the way. And if you have any questions, feel free to post them on the chat. I'm sure Bisma will tell me what those questions are. I'm having a hard time viewing the chat, but whatever, it's fine. And I know this is posting on YouTube, so I just want to make a disclaimer out here. I am a student, so please don't try to administer or diagnose or treat anybody after this rotation. Just a disclaimer out there, I am not an endocrinologist, I'm just a student. I'm a PA student. Yeah, I think I said that a lot. Okay, all right, let's just get started. I'm gonna start a case study. Can you all see my screen?
Yes.
Yes.
Okay, and you can see the PowerPoint?
Yes.
Okay, excellent. All right, so I'm gonna start right now. Okay, so I'll read this out to you and you can read it to yourself, but in the chat, I want you to tell me what you think this patient is. You're probably already familiar with these symptoms. So 10-year-old female with no significant past medical history, in with her mother with the chief complaint of unexplained weight loss, fatigue, nausea, abdominal pain, excessive urination, and thirst in the past month. Mother has been giving child Pediasure to help with weight gain, but nothing has been working. Child is up to date on all vaccination and there's no pertinent family history. What do you think this could be? Yeah, let me see, is there a chat I can see here? Okay. Diabetes. Yeah, do you know the type of diabetes that this could be? Type 1. Awesome. And what makes you think that it could be type 1? Weight loss and urination, dysuria, age. Yeah, those are all. Type 2 usually includes obesity, excessive urination, age. Yep, perfect. So this is a child who is most likely type 1 diabetic, and you can kind of tell with the unexplained weight loss, with the excessive urination, the age, and the increased thirst. Now I'm going to ask you all another question. Why do you think there is unexplained weight loss? This is kind of a difficult question. Due to loss of water in urine. Why do we think that there's unexplained weight loss? That's a good, interesting answer. So we have unexplained weight loss because in type 1 diabetes, I'm going to explain this more throughout the pathophysiology of it, is because we're peeing out all of our sugar, right? We're not utilizing it correctly. So that's why you're going to see unexplained weight loss in type 1 diabetes. All right, so what is diabetes? All right, so diabetes is an endocrine disorder which is characterized by insulin deficiency, usually due to an autoimmune pancreatic beta cell destruction, which results in hyperglycemia, which means high blood sugar, and complications such as ketoacidosis. Now, I think even for me, a lot of people think type 1 only occurs at young ages. But during my endocrine rotation, we were seeing individuals who were in their 20s, 30s, and 40s who are being diagnosed with type 1. So now the definition of juvenile diabetes is almost, I don't want to say archaic, but it's no longer used anymore because we are now seeing adults with type 1 diabetes. Now, most of the time, type 1 diabetes is occurring in young children or being diagnosed in young children. But I guess as time goes on, we are now seeing this in adults as well. Okay. Oops. Let me just want to make sure that I'm seeing your chats all right. Yep, insulin resistance, so the sugar isn't being picked up from the blood. That's a good answer. Now, insulin resistance generally occurs in type 2 diabetes, but because the cells, insulin, so what insulin is, I'm actually going to explain the pathophys here. It's going to make more sense. So how does type 1 occur? So type 1 is a T cell mediated destruction of beta cells, and beta cells are a type of islet cell. So what is an islet cell? An islet cell is a type of cell in the pancreas. The pancreas has many different types of cells, and the islet cell is one of them. And so think of islet cell as kind of like a header of the pancreas, so like it's like a group, and then under the islet cell you have alpha cells, beta cells, delta cells. So the beta cells create insulin. And what is insulin? What does insulin do? Does anybody want to put it in the group chat? What does insulin do? It's kind of in the PowerPoint, so even if you put it in the group chat. Yep, it lowers blood glucose. And Jessica, you're right, it takes sugar from the blood into our cells to make energy, right? So we need sugar, essentially, to make energy, to create energy. So insulin is almost described as almost like a lock and key type of formation. So if I were to draw a picture, right, so you have a cell, this is your cell, it's a circle, right? And then let's call this, and you have these glucose channels. So this line right here is a glucose channel, right? But insulin is, you can't just go in to this cell, right? So insulin is almost like a key. So here is a key. Probably should have made a better picture. So this is a really ugly key. Let's see, insulin, right? So insulin right here, it's a key, and it's gonna let sugar molecules into the cell, if that makes sense, right? So it's not, the cell isn't just gonna open its door for anybody. You need a key to open it. And then what do we do with that sugar? It creates energy. And that's a whole other cycle that I don't want to get into, right? So if the beta cells are destroyed, we don't have insulin, correct? So that's essentially what happens. The body, it's an autoimmune disease, it's T cell mediated, it destroys the beta cells, and now we don't have any insulin in the body that's being created, so there's no so the glucose is not entering the cell and making energy, right? Now, again, we have different, when type 1 occurs, we also have alpha cells, right? So although alpha cells are what secrete glucagon. And does anybody know what glucagon is? I know this is a lot of pathophysiology. I want to apologize for that, but hopefully this will help you with your human phys class. So what is glucagon? Increased sugar in the blood. Great, that is perfect. So glucagon increases the sugar in the blood when you have low blood sugar. In type 1 diabetes, although the alpha cells are still present, they are impaired. So sometimes in type 1s, you're going to see very, very high blood sugars because the alpha cells are confused, or you're going to see very low blood sugars because there's not enough glucagon being secreted. So there's impaired function of the alpha cells. Now, a lot of people wonder, what causes this T cell mediated attack on the pancreas? And the unfortunate reality is that we still don't quite know. We understand that there is a genetic, there could be most likely a genetic component with some environmental factors that are sprinkled in there. So some genetic markers include the HLA-DQ gene. And there's some variants of that could be a part of why type 1 diabetes occurs. Some also say that there is a viral component. So a child or an individual gets sick, the body gets confused, and then instead of attacking just the virus, it just starts attacking itself. So there's so many different theories that are being proposed, but we don't really have a full 100% complete understanding why. But we do know that there is some sort of genetic marker. So if a mother has diabetes or a father has diabetes, there is a chance that their children could also get diabetes. But in some cases, you might not even see anybody in the family with diabetes. It could just be one child and you're like, where did this come from? Well, we just don't know. Is that making sense for everybody? And please let me know if I'm talking very confusingly.
No, you're doing an awesome job of explaining everything on like a very baseline level, and you're being very clear. So thank you so much for that.
Okay, so we have so type 1, beta cell destruction. Beta cells secrete insulin. We don't have insulin if beta cells are destroyed. What does insulin do? It's a key to open up the cell, so glucose can come in and the cell can create energy. Okay, glad that we got that down. All right, and so what are symptoms? I know that we kind of discussed the symptoms of diabetes in that first little case. So symptoms of diabetes, or when you're first diagnosed or throughout the span of diabetes, is hyperglycemia. So you have weight loss, you have excessive urination, you are incredibly thirsty, you are dizzy. Some people could be very angry or irritable. You could be nauseous, you could be vomiting, you could have abdominal pain. Has anybody heard of diabetic ketoacidosis? Like DKA, you ever heard of people going into DKA? Okay. So what is DKA? So now your cells aren't getting glucose, they're not getting energy. Where are they going to get it from? They're going to get it from the fat, right? So your body starts breaking down the fat to get some sort of energy, which produces excessive amount of ketones. And so that's the breaking down of fat, which causes excessive amount of ketone, changes the pH in your blood, causing an acidosis. Okay, so the pH of your blood is becoming very, very acidic. So, that's what happens, and you can essentially die from diabetic ketoacidosis because your pH in your blood it's very, very low. And another symptom that I want to mention in a lot of diabetic ketoacidosis is that you'll see individuals come in and they're breathing really hard. They're going, and why do you think they're breathing really hard? Why do you think they're having like a long expiration? O2 makes blood more basic. You're really close. You're very close. So we're blowing out to release CO2. Wonderful, wonderful. We're releasing CO2, right? because their blood is acidic. So that's kind of what your body is doing to release, to make it less acidic. So it's just kind of like a sort of mechanism that your body is going to do. And you're going to see people going, and this type of respiration is called cosmal. I think I'm saying that wrong. Cosmal respiration. So that's what you're going to see in individuals who are in DKA. A lot of abdominal pain, some vomiting as well. Now I think I had this question almost myself, was ketosis with the keto diet and diabetic ketoacidosis, right? Like, I think, you know, a lot of people benefit from the keto diet, but what's the difference between diabetic ketoacidosis? Why don't we die from like the ketone diet? Well, the ketone diet is a question that I had as well. It's because you're not creating as many ketones as you are in diabetic ketoacidosis. Your cells have zero energy in diabetic ketoacidosis, whereas like the keto diet, you have some reserve of energy as well. And your liver is creating glucose still so that your cells can have the energy. So that's why you won't have a ketoacidosis with the keto diet. Just FYI, if anybody was wondering, because I always did. Is it normal for diabetics to be in DKA if they have their diabetes under control, or is it mainly uncontrolled diabetics? That's a really good question. So the thing with diabetes is that with a lot of type 1s is that anything can actually put you in DKA. So for example, if someone gets sick, it can put you in DKA because your body isn't under so much stress. So even if you'll see the most well-regulated diabetic, they can go in DKA in certain conditions. But yes, you will also see DKA much more commonly in uncontrolled diabetics as well. Does that answer your question? No, okay. All right, so how do we diagnose diabetes? All right, awesome. So generally, I know with type 1, you're gonna see unexplained weight loss, nausea, vomiting, abdominal pain. But let's say you're kind of in this stage, an adult, right? Where they haven't had that much weight loss, but it's like kind of weird, and they're eating a bunch and they're like, wow, I'm losing all this weight and I just keep eating. Well, that's not good. You shouldn't have unexplained weight loss, right? But you know, they go to the doctor and the doctor wants to run some tests and they think this could be it. So something they will do is a fasting blood glucose. So your fasting blood glucose, if you have something above 126, and that's your blood sugar, you could be type 1 or type 2. If you have symptoms of hyperglycemia at a random blood glucose and it's above 200, it could be type 1 or it could be type 2. If your 2-hour plasma glucose test is above 200, so a plasma glucose test is when you take 75 milligrams of carbs or 100 milligrams of carbs and you wait 2 hours, and if your blood sugar is above 200, you could be type 1 or you could be type 2. Now, what differentiates type 1 again and type 2 is the autoantibodies, right? So in type 1s, or you're not sure, you're going to test for, you're going to do a blood lab to see if they have any autoantibodies against islet cells, and you're going to check a C-peptide, okay? So the differentiation in the lab work, besides the blood sugars, is going to be the autoantibodies. So the autoantibodies against the islet cells, right, which are the insulin cells, or a C-peptide. C-peptide is just basically a substance that's made alongside with insulin. So if you have no insulin, you're not going to have any C-peptide. Does that make sense? Okay, I hope that makes sense. And anybody stop me if I'm not making zero sense. Okay. All right. So lucky for us, you know, diabetes treatment and therapy has come a very, very long way. So we have multiple different types of medication and therapies that individuals with type 1s can go on to help them become well controlled. So I'm sure all of you or some of you have heard of insulin, and there's multiple different types of insulin, right? We have a rapid acting, which is what most diabetics are on. We have a short acting, we have an intermediate, and we have a long acting insulin. So I'm going to show you what rapid acting insulin, or what insulin generally looks like. So it's this vial right here. So this is Novolog, and Novolog is a rapid acting insulin, and this is generally what most type 1s are on. Okay, so it takes about 15 minutes to work. The peak time is about 2 hours, and then it lasts about 4 hours in the body trying to regulate those carbs that you've taken in. The next medication that most diabetics are on, if they're not on the insulin pump, which is what I'm going to show you, is the Lantus. So Lantus, think Lantus long acting. I'll show you right here, Lantus. Lantus lasts 24 hours. Okay, now I'm going to ask you a question. Why do you think we use a short acting insulin, and why do you think we use a long acting insulin? There's no right or wrong. I mean, there's a right answer, but I don't care if you're wrong, it's fine. So why do you think we use a short acting insulin, and why do you think we use a long acting insulin? That's Jessica, you have been killing it. So short maybe to control a meal, perfect. Long acting is for when you sleep at night. That's a really good answer. So generally, it's close. So most diabetics will take the long acting at night. And what this is so it lasts 24 hours. So our liver is always kind of dumping out glucose, right? It's dumping out glucose at random times. So this long-acting insulin is for that. It is to help with the random dumps of glucose your body is going to dump in your blood. That's something you have no control over. The short-acting insulin, as what you guys were talking about, is to control it's for your meal coverage, right? So before someone eats, they're going to drop. Now, most diabetics now use these long pens, really cool pens. I just have these here. But back in the day, you had a syringe, you would draw up a couple units, take it hopefully a couple minutes, 10 to 15 minutes before your meal, put it in, and then you would eat. So that's the meal coverage. This is liver coverage. I made the liver coverage up, but that's what I mean. Okay, so let's start to calculate insulin dosages. This is something that I learned at my endocrine rotation. I thought it was super duper cool. And hopefully you guys get to learn a little bit of that too. Okay, so now we learned that there's the rapid acting, and the long acting, okay? So we're going to, so when a type 1 goes to their endocrinologist, because that's who they see, right? The endocrinologist is going to estimate their total daily insulin usage, okay? Their basal means long acting, their carb ratio, so how much insulin is needed for the amount of carbs they eat, and their insulin sensitivity factor. The insulin sensitivity factor is how many units of insulin, the rapid acting insulin will decrease your blood sugar, okay? So we're gonna calculate that today. It's gonna be a little confusing, but then I'll give you a practice problem so you guys can all do it, okay? So what we like to use is we like to use a range, right? When we're calculating the total daily insulin use. When a type 1 is first diagnosed, we use a range and we multiply it by their weight. And that will give us their estimated total daily insulin usage. Okay, so the range is generally for type 1s 0.1 to 0.8. Okay, 0.1 you use if they have a high insulin sensitivity, like they're lean, they're very skinny, they don't need that much insulin. And 0.8 and above is generally when they have some sort of, body weight, increased body weight, or the amount of insulin, they need more insulin requirements. They require more insulin. But I'm just gonna make it easy for you, and we're gonna start at 0.5, okay? So you take a number out of this range, so I'm gonna use 0.5, and let's say somebody's 50 kilograms, okay? So you multiply 0.5 times 50, and then you get 25 units of total insulin. Okay, that's what you think they're gonna use throughout the day. Does that make sense? Is that confusing? Okay, so just use 0.5 because that's just gonna make it easier for you. Things will change when you're in practice and if you go into endocrinology. Now, to make things, now you got the total units of insulin, right? That's your rapid acting insulin. Now you need their long-acting insulin, okay? So now you take 50% of their total daily insulin usage, right? To get the long-acting insulin. So you take 25 times 0.5, which is 50%, right? And you get about 12.5 units, or you can round up to 13. So you're gonna be giving them 13 units of Lantus every night. Or every morning, it lasts 24 hours. Does that make sense? So now we have the total daily insulin, which is their rapid acting insulin. And now we calculated their long-acting insulin that we're gonna use every night or every morning once a day. So that's about 13 units. Okay. Next, so we estimated their basal. So they're using 25 units of short-acting and 13. So, yep, so they're using 25 units of short-acting per day. So per, like if you divide it up, generally estimated, they're using about 25 units per day and 13 units of the long acting. So the total is 38, yes. But again, I want you to think like, I don't want you to think that they dose 25 units every time they eat. Does that make sense? They're not just taking 25 units every single time they eat. And that's when the carb ratio comes in. So I don't know if I answered your question correctly. Is that making sense? Yes, they're using a sliding scale. Perfect. So a sliding scale is essentially the carb ratio, right? So the amount of units of insulin to give per carbs. So let's calculate the carb ratio. So the carb ratio, you can use 450 or 500 and divided by the total daily insulin usage. Okay, so let's say this is a newly diagnosed type 1. I don't want to be really aggressive, so I'm not going to use the 450, I'm going to use the 500. So 500 divided by 25, you get 1 unit. All right, 500 divided by 25, what is that? That's 20. Let me fix that. You get 20 units, I'm sorry, 1 unit for 20 carbs. Okay, so you take 500 divided by the total daily insulin of the rapid acting, and you divide it by 25, and you get for 20 carbs, you take 1 unit. So what's 20 carbs? Maybe a granola bar, right? So I'm gonna eat this granola bar, it's 20 carbs. I'm gonna give myself 1 unit, and that's it. Okay. Now we have to calculate the insulin sensitivity factor. The insulin sensitivity factor is used for people who gets the high blood sugars, let's say you got a high blood sugar after eating, or you forgot to give yourself insulin. Well, you need to figure out how much insulin to give yourself to go back down, right? So the insulin sensitivity factor, you're going to either use 1700 for aggressive or 1800 for less aggressive, and divided by the total, the TTD, so the total daily insulin, whatever it is, right? So we did 1800 divided by 25, and we figured out that 1 unit of insulin will bring you down 72 milligrams per deciliter, and that should give you your insulin sensitivity factor. So generally, we prescribe this for individuals whose blood sugar, so if your blood sugar is over 150, let's say 4 hours after a meal, use this insulin sensitivity factor, okay? So 1 unit is gonna bring you down 72 milligrams per DL. Does that make sense? All right, now, I'm gonna have you guys do a practice problem. I don't know if you guys are writing this all down. I know it's kind of confusing, but you guys can try. All right, so we have a 20-year-old female whose weight is 55 kilograms. I want you to calculate her total daily insulin usage, calculate her basal rate, so her long-acting she's gonna need, calculate her carb ratio using the 500, and calculate her insulin sensitivity factor. And I'm gonna give you guys, and if you guys need me to go back into your slides, or if you need me to write down anything here, let me know. So I'll give you 5 minutes. My phone's about to die. I know that we don't have much time yet. I feel so bad. And you can put your answers in the box. So what's the total daily insulin that you got? 27.5. So it looks like everyone got the total daily insulin. Very good. Okay, how about the basal rate, the long acting? So you have to, perfect. Okay, how about the carb ratio? Carb ratio, so we take 500 divided by the total daily insulin. Oops. 500 divided by TDD for carb ratio. And 1700 divided by insulin sensitivity, 18.2, good. Beautiful, good job everybody. You guys are geniuses. See, I didn't know this in my didactic year and now you guys know it. All right, how about your insulin sensitivity factor? Beautiful. So 1 unit of insulin will drop you down about 61 or 62 mgs per DL. Beautiful, beautiful, beautiful. Great job, great job. Okay. Oh, awesome. Okay, now we're going to continue on. Now, I'm just going to try to speed it up because I know you guys have PA school questions and we're done in about 20 minutes. So when someone's diagnosed with type 1, you want them to check their blood sugars, right? So you're going to tell them you have to check your blood sugar in the morning. You have to check your blood sugar before meals and 2 hours after meals and right before you sleep, right? You want to tell them to check your blood sugar in the morning because you want to know if the basal is working. So if you're above, generally we want them in between 80 to 110. So if they're above that in the morning time, we have to adjust their long-acting insulin. Before meals, after meals, of course, we want to make sure that that correction is, that insulin to carb ratio is working. And when you sleep, so they don't accidentally fall asleep on the low. So I talked about hyperglycemia. You're going to get nausea, you're going to get vomiting, you're going to get abdominal pain, but hypoglycemia. So why does hypoglycemia occur? Hypoglycemia is generally going to occur when, one, somebody accidentally takes way too much insulin, right? Or they forget to eat and they took insulin. So hypoglycemia is much, much more dangerous because, one, individuals, you don't have any like sugar or energy in your brain. You have low blood sugar. So that's why some people will pass out. You're going to have, some people will have seizures. Not everyone has seizures. Okay. You're going to be shaky. You're going to be sweaty. Some individuals have perioral numbness. So their mouth and tongue are numb. Extreme hunger. Hypoglycemia is generally characterized by blood sugar below 70. And so it's incredibly dangerous, especially if somebody is driving and they start getting hypoglycemia. It's a medical emergency. Below 70, you can correct it if they're conscious, but when they start hitting 30s and 20s and they look like they're about to pass out, or if they're unconscious, it's a medical emergency. They should go to the ER, or you probably will be familiar with the glucagon shot or the Baqsimi, which is a nasal spray. Now, let's say someone is conscious, their blood sugar is 50, they're awake, they're well, they're fine, and they check their blood sugar is 50. You tell them, take 15 grams of carbs. So that could be, like a Reese, 1.5 Reese's, right? Because each Reese's is 10 grams of carbs. And then you wait 15 minutes and you check your blood sugar. So it's called the 15-15 rule. 15 grams of carbs, check your blood sugar in 15 minutes, okay? All right, let's keep going. Now, many type 1s are on pumps, okay? So some of you guys have seen them, some of you haven't. So I'm gonna show you what a pump looks like. This is a Medtronic pump, all right? And it comes with a continuous glucose monitor. A continuous glucose monitor is essentially that continuously checks your blood sugar throughout the day, so you don't have to constantly prick your blood sugar. There's multiple different types of continuous glucose monitors. There's actually 3 really big companies. There's the Medtronic, which is the one I have, the Tandem, and the Omnipod. My personal opinion, I'm seeing better results with Tandem because it has more aggressive control on the hyperglycemia. But that's just me. I'm not being paid to say that. I have a Medtronic right over here. So this is kind of what they look like. So you have a little tube thing right here, right? Little reservoir. And it's generally attached to somebody's stomach, like right around here. In their stomach area, or they can have them on their flanks. Some people put them on their legs, but it's not recommended, generally on the legs. Some have them on the arms, but most people don't. So around the stomach areas, kind of big areas, are places where there's more fat. Complications with diabetes, I'm sure you've heard of them. So the state of hyperglycemia causes micro and macrovascular dysfunction of this. So micro and macrovascular, as in the vessels, so your arteries and your arteries in your veins. So they decrease the elasticity, so how well they open up and close of the vessel, which if they're too tight, if they're not able to open up enough, you're getting decreased blood flow to those blood vessels. So you're going to start to see end organ failure, such as kidney disease, coronary artery disease, which are the arteries on your heart, and polyneuropathy and peripheral neuropathy, which is like your fingers and toes. So generally type 1s and both type 2s should be checking their fingers and their toes to make sure there's no wounds. Because if you get those vessel damage, nerve damage, vessel damage, they're not going to feel those wounds, right? And you're going to have problems where their wounds are getting infected. Another thing is that diabetics, both type 1 and type 2, should be getting yearly eye exams. So diabetic retinopathy is a huge complication which leads to blindness. So diabetic retinopathy is essentially damage to the blood vessels in your retina. So those vessels are hemorrhaging in the back of your eye. So they should be getting yearly eye exams. I wanted to discuss on diet, but there's a great app called Calorie King. It's not a great app, it's an okay app. It's called Calorie King. Generally, it has a bunch of foods that you can type up and see how many carbs that you have. Diabetics should be counting their carbs so they're not guessing on everything, but sometimes when you're at a restaurant, you don't really know what it is. But Calorie King is a great app that they can use. You should always emphasize a healthy diet for everybody, not just diabetics, just because, you know, I'm seeing even in the hospitals, people are dying from obesity. They're dying from environmental factors, you know, such as smoking and alcoholism and being overweight. And that's, you know, you can prevent that through a proper diet. And with type 1s, I always recommend diabetic education and nutrition information, especially in the beginning, to make sure that people are on top of their health. Now, I don't have much time, but I wanted to talk a little bit about mental health, and then I'll end there. So we always wonder, why are diabetics so gosh darn under control, not under control, out of control? Why aren't they giving themselves insulin? Why aren't they checking their blood sugars? So diabetes requires chronic management every single day and almost every single hour of the day and every time you eat. It's a lot of work. It's a ton of work. So there comes an exhaustive phase of constantly pricking your fingers before you eat, checking your sugar after you eat, even before snacks, giving yourself insulin, and not being perfect at it, being angry when your blood sugars are dropping, being angry when your blood sugars are going up, and feeling like a failure. So depression from chronic management of a disease is a very real thing, and it's something that you should be talking with your patients about. Depression is very real, and it's especially real in individuals with any chronic illness, especially when diabetics feel like type 1s, especially, there's not a whole lot of people who are like them. They might be the only person in their family with type 1 diabetes. So they feel like they're just managing it themselves. So keep that in mind. Diabulimia is also something where individuals won't take insulin to lose weight, and that can cause death, by the way. Eating disorders are very common as well. I have things about islet cell transplantation and the future of diabetes, but I want to leave these last 10 minutes to questions that you may all have. That's pretty much all I have for today. So these last 10 minutes, do you all have any questions about PA school and anything like that?
Thank you so much, Maria. That was awesome. Parshva, if you want to, you can administer the survey in the chat, but we can actually start talking about PA school, your undergrad experiences, everything like that. So if you guys all don't know, Maria is actually my cousin. So I grew up, you know, seeing her go through her PA school journey, and she's been really inspirational to me. She has her own Instagram account where she kind of documents her journey. It's called The Anxious PA Student. And she also did have like a YouTube channel for a little bit. So Maria, if you kind of want to talk about your experiences at Western University and talk about your undergrad experiences at OU and why you chose PA.
Yeah, those are all great questions. So I'm at Western, and I had a great experience at Western, especially with the COVID that had happened. You know, I was really worried that I wasn't going to get my rotations in and I wasn't going to graduate on time. But, you know, my school was able to really get us out there and be sure that we were going to be out there, get our clinical experiences. So if that's a question in regards to COVID. So I have a couple questions here. Since you graduated with a health science degree, did your degree fulfill some of your prerequisites? Yes, my degree was actually able to fulfill like about 99% of the prerequisites that I needed for PA school. I did graduate from Oakland University with my health science degree, and that health science degree is a very versatile degree, as in you can end up, you know, fulfilling your med school requirements, your PA school, I think even dental school requirements. Sandra's asking the difference between a nurse practitioner and a PA. So the essential difference between the nurse practitioner and the PA is that to become a nurse practitioner, you need to go to, you need to become a nurse first. You need to become an RN first. PA curriculum at Western. Okay. Sorry, I feel like I'm going to try to answer all your guys' questions. So the nurse practitioner field, you need to become an RN. I don't know if you need to have like certain amount of hours and then apply to NP school, but that's the biggest difference. With PA school, you need a certain amount of clinical hours. So you need about 1,500 to 1,000 clinical hours, right? When you apply, you need to have certain school prerequisites fulfilled, and you need to have letters of recommendation as well, and you need to fulfill the GRE. But I think that might be changing now, unfortunately. The GRE, now there's going to be something called the PAC-RAT. Not the PAC-RAT, excuse me. There's going to be something else. The PA-CAT, something like that. It's called the PA-CAT. I don't know if a lot of schools are adopting that, but that's the biggest difference. Can you talk about the PA curriculum at Western? Yes, I can. So the PA curriculum at Western Michigan it's module based. So what I mean by that is that about every month and a half, you have a module, and that module is based on an organ system or a disease. So for example, if we were on the cardiology module, we learned about all the cardiovascular diseases. We learned about the pathophysiology of the pathophysiology of each cardio diseases. We learned about the anatomy of the cardio. We learned about the pharmacology of the disease, the cardio diseases, if that makes sense. So then the next month we learned about pulmonology. So we learned about all the pulm diseases. We studied the lungs. We studied the pathophys of that. We studied the pharmacology of that. So I hope that makes sense. So I don't know what other PA schools teach, but that was how they taught. So a module or an organ system, we'd learn all about it, and then we'd go on to the next module and organ system. In this chat is also my classmate Lisa. She's also at the Western with me, and so you know, Lisa, if you want to chime in and type in the chat to help me out here, feel free to. Okay, do you have volunteer for PA school? If so, do you have any recommendations for volunteer work? So I did have volunteer experience. I had about 300 hours of volunteer experience. I think that was a little bit of an overkill though. So I worked at a garden, like a organic garden in Detroit, and I was a board member in that garden. So I would go out to that garden. I would plant some corn and plant some vegetables, and then I would give it out to the patients that were next to that clinic, because we had a really bad, we still have a really bad obesity epidemic in Detroit, and lack of kind of a food desert there. So that's kind of what I did for my volunteer experience. I also did a lot of volunteering through clubs as well. So for example, I was part of the Muslim Student Association. So if they had a bake sale or something, I would be a part of that. I recommend for volunteer experience is that anything that you really enjoy. It doesn't have to be medical related. If you want to sew blankets for people who need blankets, like, do it. Do something that you enjoy, do something that you're passionate about. It can really be anything. I think PA schools kind of want to see a well-rounded individual. It doesn't always have to be med. What did I do for clinical hours? So I was a medical assistant for about 2-ish years. And then I was a behavior technician for about another 2-ish years. As a medical assistant, I didn't get any certification, but I did get a phlebotomy certification, which is a blood draw class, so venipuncture. So I would, I just wanted to learn that because, well, I don't know how to give blood draws, and I didn't want to just give a bunch of people blood draws without the proper training for it. It was about $500 for the course, and it was 4 weeks long. It was great. I liked it. And then I just kind of applied to outpatient clinics and, got hired in. So I recommend, if you have, at Oakland University, we had something called Handshake, which was, a job search type of thing, and I would apply all through there and every single clinic I applied to, and eventually I got it. So that's what I would recommend. And in fact, I would also recommend, if you really want to get patient care experience, I would recommend, starting out volunteering in a clinic, and then just kind of shadowing the medical assistants there and seeing what they do and trying it out yourself for free. That's what I did in the beginning as well, is that I volunteered at a clinic. I shadowed the medical assistants. They let me do EKGs and take vitals and taught me how to do that. And then when I got that phlebotomy experience, I started applying to different clinics. You've had a lot of patient experience. Can you share how you got the? Please tell us how you gained your patient care experience. Which PA requisites helped you the most in PA schools? Are there any courses you recommend we take before PA school at best to prepare? Ooh, okay. So patient care experience, I think I answered that. Which PA school requisites helped me? So I would say that the most, I feel like when you do a health science or biology degree, or any kind of scientific degree, you kind of build that foundation for PA school. And you kind of, when you get to PA school, you kind of understand the pathophysiology better. So for example, when I was mentioning T-cell mediated cell destruction, if you take a human physiology class, I mean, you know what that is, right? I want to say that PA school isn't necessarily difficult as organic chemistry or physics, but it's just a lot of memorization, so it's not complicated, but it's just the sheer amount of information given to you at a small amount of time. And like Lisa's saying, your human bio and human physiology classes are going to help you. Anatomy, I think, is definitely just getting your feet wet in the water with a cadaver lab. Okay. You're getting your feet wet is important, because if you kind of just, when you go to the cadaver lab and you haven't had any cadaver experience, it can be very overwhelming if you don't have any experience in that, because there's so many different structures and vessels, and that can be the hardest for some students. Do you have students in your class who receives a Bachelor of Arts degree? I was wondering if PA schools prefer a Bachelor of Science than a Bachelor of Arts. That's a good question. I don't know. I don't know if Lisa can answer this. You know what? I think the thing is that as long as you have your prerequisites, your science prerequisites that you need to fulfill for PA school, and you have your clinical experience, I think you should be fine. And you have good letters of rec. I also know someone who had a Bachelor of Music degree and went to Wayne State, Wayne State's PA program, and she was a music major, and she fulfilled her prerequisites in her clinical experience. So I think that's kind of cool. You know, I think you can get any degree as long as you get good prerequisites.
All right, I think we can wrap it up there. Thank you so much for the incredible and insightful session, Maria. I really enjoyed how educational that was, and I really hope we can have a session with you again in the future. If you would like to post your social media handles or any links in the chat, please feel free to do so. To our Wayne State University students, please make sure you complete the Google survey posted in our Zoom chat summarizing the session to obtain your shadow hours. Thank you all, and I hope you have a great night. Please feel free to hang around the call to make sure that the survey is working for you.
All right, I know that someone had one last question, but you can text me that on my Instagram, and I'll answer it for you.
Thank you.
All right, thanks for having me. And all right, have a great day. Bye-bye.